Hello, and today's lecture is about chronic myeloid leukemia. Chronic myeloid leukemia is one of the most common myeloproliferative diseases. And what we mean by myeloproliferative disease is the disease of the bone marrow, where there is going to be myeloid, one of the most common, but it is definitely not the most common, one of the most common myeloproliferative diseases. And what I was saying is that it. It is a disease that involves the bone marrow because myelo is the myeloid cells, the myeloid generation of cells. But the most common myeloproliferative disorder is your CLL, that is chronic lymphoid leukemia, and that we look into in this particular video as well. So CML, actually, you should know that there is one very important translocation of chromosomes, that is 922 chromosome, and that is something which is associated with BCR ABL translocation. Now, when you think about it, in a BCR ABL translocation, has a tyrosine kinase activity, and tyrosine kinase activity causes increased proliferation of the myelocytes. All right, so there's going to be increased proliferation of myelocytes because of this translocation. So let's say if there is a gene on 9 that is BCR, the BCR gets translocated to the ABL side. ABL side is a tyrosine kinase, and there's going to be increased proliferation. In that sense, since in that sense we've been speaking, so there's going to be increased proliferation, and increased proliferation is going to cause what? Most of the diseases that we've seen in acute cases, acute myeloid leukemia, we've seen that it causes a pancytopenia, and even an acute lymphoid leukemia, we've seen that causes a pancytopenia. And whenever there is an increase in the WBC count, or when there's leukocytosis, it's usually seen as a bad prognosis. But when we're talking about a chronic myeloid leukemia, we see that there is going to be increased extramedullary hematopoiesis. The platelet count is going to be high, and usually in acute cases there is very little extramedullary hematopoiesis, but in a chronic case there's going to be a very high chance of extramedullary hematopoiesis. So for that reason, because of the extramedullary hematopoiesis, there's going to be increase in the platelet count, there's going to be increase in the WBC count, there's going to be increase definitely there's going to be increase in the total leukocyte count, and lymphocyte count, obviously. Right. So there are going to be three phases of CML. First is the accelerated phase, first is the chronic phase, then the accelerated phase, and then the blastic phase. And we'll get into the phases as well. But before we get into the phases, all right, we need to understand that what is this also called as T922. Well, it's also called something called as a Philadelphia chromosome. It's really interesting that it's called a Philadelphia chromosome. And what are the risk factors? Well, the risk factors are high dose radiation, and it can be associated with juvenile myelomonocytic leukemia. And those are certain variants of CML, and the variants of CML, if I have to talk about before I get into CML proper, one is your, as I said, juvenile myelomonocytic leukemia, where actually the BCR-ABL thing that I explained, the translocation is not really present, but it's associated with RAS, that is RAS mutation. RAS mutation has been seen with a lot of colonic cancers, especially in APC KRAS mutation. But let's not get into that for now. If I have to explain in short, obviously it's a KRAS mutation. Then there is a mutation in eventually there's a mutation in P53 that makes it cancerous, but there's a KRAS mutation. Also, there is a mutation first there's an APC gene mutation, then there's a KRAS gene mutation, obviously, and then there's a P53 mutation, and that's for the colonic cancer. But here I'm talking about RAS mutation. So RAS mutation is also associated with neurofibromatosis and rash, from RAS to rash, thrombocytopenia, and anemia. So that is juvenile myelomonocytic leukemia. We also got chronic neutrophilic leukemia. Again, it is associated with no BCR-ABL. So all of these forms that I'm talking about, they do not have BCR-ABL. All right, they do not have that translocation. And the second is, as I said, chronic neutrophilic leukemia. It's associated with colony forming unit mutation. So CSF, or stimulating factor, colony stimulating factor mutation. All right, so colony stimulating factor is when it's overproduced. Colony stimulating factor, it actually causes this entire chronic neutrophilic leukemia. Also there's BCR, there's also chronic eosinophilic leukemia. Chronic eosinophilic leukemia is also very similar to chronic neutrophilic leukemia, but it has PDGF, polyglutide growth factor positive mutation, all right, and CSF positive mutation. That is the different types of leukemia. I do not really want to waste much time on it, and I would definitely again jump back into CML. And as I speak into CML, I had told you that CML can be due to BCR ABL, and then we will check also into those very important points about the three phases, right? So before we go into the phases, or we can directly start from the phases, actually it does not really matter. So there are three phases, as I said. One is the chronic phase, all right, one is the accelerated phase, and then is the blast crisis. So the chronic phase is when your CML is when you're having a myelocytic proliferation. Then your accelerated phase is when you have gone into a very severe proliferation. Your blast cell counts are increasing 20, and you're going towards an acute kind of presentation, all right. And then blast crisis is when you've kind of converted yourself to an acute phase, that's an AML. So let me tell you, from when you're in your CML, you go into accelerated, you kind of become into an intermediate form between CML and AML, and then you become an AML. So that is the three phases. So it's a very big overview that I'm kind of giving before we directly go into the symptoms. So again, I want you to understand the symptoms going to be following three phases, right? So when you're talking about the chronic phases, it's kind of asymptomatic, right? Because I'm telling you that extramedullary hematopoiesis is also occurring, but obviously there's going to be anemia. There's going to be certain amount of anemia, not a lot of anemia, but definitely certain amount of anemia. There's going to be fever, there's going to be weight loss, all right? There's going to be weight loss, and there's going to be night sweat. But what I told you is that there's going to be extramedullary hematopoiesis. That means there's going to be HS-megaly, hepatosplenomegaly, and more importantly, very important to understand is that splenomegaly is going to be very, very prominent. Also, you're going to have a lot of gouty arthritis. Gouty arthritis is simply because of the high turnover of cell, and gouty arthritis you can see as negatively bifringent crystals in when you do your routine scanning, and you can also see high level of uric acid, all right. And whenever there's uremia and uric acid, it also predisposes to a lot of dilatic cardiomyopathy, especially uremia in diabetic patients. So that's also something that can be kept in mind. Also very important is to understand that you will have a lot of basophils. If you see basophils, you should think of two things, AML or CML. Now, if there is a chronic presentation, you want to think more of a CML. Also, there's going to be histamine, and there's going to be, because of basophil, there's going to be histamine, which is going to cause acne and urticaria. Acne and urticaria is something that is associated out here. Also, another place that acne and urticaria are going to be associated is with definitely with polycythemia vera. Polycythemia vera is going to cause post bathing rash or urticaria. Very important, very, very important. And there's going to be hyperviscosity. Hyperviscosity is very, very important, and leukocytosis related syndromes. Now, what I want you to understand is that the entire syndromes that we're talking about, I haven't spoken about less thrombocytopenia or even a lot of infections as such, is simply because of the fact that in the chronic stages, extramedullary hematopoiesis is fine, so therefore it's going to take care of all the other blood variants, and is not going to cause platelet deficiency or WBC deficiency. So on a peripheral smear, when you see in a chronic stage on a peripheral smear, if you've been picked up by a hematologist, you will definitely see that there's going to be increase in type of cells, and there's going to be a very high increase in type of cells. Usually these patients are picked up by increased basophil count, increased metamyelocyte, increased myelocyte, band forms or segmented forms are going to be increased. So what's going to occur is that there's going to be a lot of myelocytes in the blood, and there's going to be a left kind of shift, right? And when you have the shifts that is left and right, when there's an RBC, when there's an vitamin B12 or B6 or B9, mostly B12 and B9 deficiency, what is actually happening is that there's going to be a right shift to the neutrophils. That is, there's going to be older neutrophils in the body. There's going to be neutrophils for a long time. But now let's say if there are diseases like CML, there's going to be younger neutrophils that are coming, or there's an infectious disease, there are going to be younger neutrophils that are actually coming. So that's really important for us to understand as well. Younger neutrophils means less number of nodes. lobes, and older neutrophils means more number of lobes. So we can check that out as well. And then when you do a bone marrow biopsy, there are three conditions in which bone marrow biopsy is contraindicated. One is your hairy cell leukemia, other is a myelodysplastic syndrome, and even your myelofibrosis to a certain extent. So what happens is that in hairy cell leukemia, there's going to be fibrosis and primary myelofibrosis. Very important to understand is that there's going to be a lot of fibrosis, and that is going to cause but hepatosplenomegaly is very, very prominent in myelofibrosis. But myelodysplastic syndrome is a syndrome where there's going to be a lot of improper division, and hepatosplenomegaly is going to be absent. So there's going to be a very rapid decrease in all the cell blood constituents. That's pancytopenia is going to be seen with thrombocytopenia, leukocytopenia, and thrombocytopenia, and definitely you're going to see certain amount of we're also going to see certain amount of we're going to see these kind of cells trying to escape from the bone marrow. So when they're trying to escape from the bone marrow, they're going to have these inappropriate structure, definitely inappropriate structure, and megaloblasts, nucleated RBCs, because they're trying to get out. And very important is pseudoplagular Hewett cells, Dole bodies, myeloblasts that have been seen. Again, 5q mutation is seen. And I can go on and on about this entire thing. What's important is that we understand that more than myelofibrosis, myelodysplastic, we have to look into myelofibrosis. And myelofibrosis is the one where you contraindicate your right hap, all right, because of the fact that there's severe collagen deficiency. And you're going to see a lot of Sweet syndrome, leukocytis, autosclerosis, bleeding, anemia, thrombocytopenia. All of these conditions can be seen, and that is about it when it comes to primary myelofibrosis. Now coming back to biopsy, on biopsy you see C blue histiocytes. On biopsy of CML you see C blue histiocytes. And pseudogaucher cell. Pseudogaucher cells are kind of wrinkled kind of cells that are like wrinkled or crumbled paper. All right. Definitely you're going to see decreased hemoglobin, HS megali, and LAP is going to be leukocyte alkaline phosphatase is going to be high, but in PC, in polycythemia vera, you're going to have increased LAP. Alright, so that's kind of an important fact that we have. Increase LAP, polycythemia vera, increase LAP. Very important, because there the WBC count is going to be more, but here the WBC count is more, definitely small, but it's metamyelocytes and myelocytes. They are not completely mature WBC cells because of the increased proliferation. So obviously the LAP is less, and LAP is also going to be more in leukocyte alkaline phosphatase, is more in infection. So that's a kind of an important differentiation when you want to make sure that is it an infection, is it a chronic infection that we are looking into, because a chronic infection can also present as an anemia of chronic disease, and then again your anemia could hint towards an anemia of chronic disease. And out here definitely it's an anemia of chronic disease, because CML actually causes anemia of chronic disease, and that's why we are saying that is anemia, but that is my level of anemia. And it's very interesting about the entire correlation that we have. Then what actually occurs is that in the accelerated phase, as the interleukin 6 increases, there's going to be anemia, and the anemia is going to become more and more profound, and there's again going to be normocytic normochronic anemia. Blood and bone marrow is going to be kind of 10 to 20% blast. Well, when I say actually CML, we do mean that they're going to be blast, but going to be increased metamyelocyte. But are they going to be blast? Well, now we are talking about blasts. So blood and bone marrow blasts are going to be almost 20%. Thrombocytopenia is very important. Platelet count is kind of less than 1 lakh. So then you would go into a blast crisis, and a blast crisis would be that would be basically greater than 20%, and LAP would be very, very high, because your leukocyte leukocyte alkaline phosphatase now gradually increases. Okay, now that's something that hasn't been understood really well, but that's something that we should remember, that leukocyte alkaline phosphatase increases because it is kind of changing into an AML. All right, it has switched to an AML. So pancytopenia is also correct. Now there are two prognostic scores that we should keep in mind. One is the so-called prognostic scores. So-called is basically age, spleen, platelet, and blasts. Okay, so the amount of blast. So if your scorecard score is like less than 0.8, you're fine. 0.8 to 1.2, you're at a kind of an intermediate risk. And if it's more than 1.2, you're at a high risk. And how do I remember SOCAL? SOCAL actually include SO is for spleen, O looks like a platelet, K looks like, well, K doesn't look like anything, but A looks like an age, it basically means age, and L is, in spite of it being a SOCAL, we say myeloblast. All right. If there's going to be a myeloblast, you have to think of SOCAL. You want to know management of CML? CML is one of the easiest. It is quite a nice condition to manage, because you have first to control your tumor lysis syndrome. You could do that with allopurinol or febuxostat. Febuxostat is mostly preserved because this is an allosteric inhibitor. Yes, this is an irreversible inhibitor. So febuxostat present is used. All right. We can also give hydroxyurea. Hydroxyurea is given here, and it's also given in HBS. Correct. That is sickle cell disease. Why is it given? Because see, hydroxyurea is kind of going to prevent the conversion of IMP to CM. Well, it's actually going to prevent a lot of things. It's basically going to prevent DUTP to UTP. So this entire process is going to be prevented by hydroxyurea, one of these processes, when it comes to de novo synthesis. So that's why it's kind of important. Also, what we can do is we can do tyrosine kinase inhibitors. Why? Because imatinib is the answer. Imatinib is the answer. Why? Because tyrosine kinase inhibitor has kind of increased BCR ABL. ABL is a tyrosine kinase channel. So domain response to imatinib. Now we've also called this very important, dasatinib, but it has got its side effects like pleural effusion, pulmonary artery hypertension, QT prolongation, stuff like that. So it's got pulmonary hypertension, pleural effusion, and QT prolongation. And bosutinib is quite interesting. Bosutinib is the one that is now also having quite a role. All right. So those are the important drugs. Bosutinib, any nib is the management of CML. So how do you check? You basically do a molecular response, your transcription of BCR-ABL every 3 months. You also check your blood counts every 2 months, and you do a bone marrow every 6 months. All right, so you would know exactly how well this is responding. In most cases, it does respond pretty well. CLL is the most common type. As I told you, CLL, I'm jumping onto CLL. CLL is the most common type. CLL, if you want to understand CLL, you need to understand the different markers, because that is basically giving it up. All right, so CML, ALL are the two where your markers are kind of important. Now, if there's an ALL is of two types. One is the pre and the pro. Pro is the better one, pre is the better one. Pre is associated with CD10, CALA positive. Pro is associated with TDT positive. TDT is important, TDT, and PAX5. And TDT is kind of a marker of an immaturity, so that's kind of important. And very, very important is to understand the chronic lymphocytic leukemia. Now, what's actually occurring in the CLL is that there's going to be increase in activated B cells. It's going to be increase in activated B cell. And activated B cell, I mean by mature B cell, not immature. So there's going to be pre-pro, immature, which is going to be CD19 positive, and there's going to be mature, which is going to be CD5 and IgM positive. All right, so that's going to be how your immunophenotyping is going to be in CLL. So it could be CD19 positive as well, and undergoes a so the mature B cells are going to increase. All right, so very important is to understand is that we have one of these processes where the mature or the naive B cells undergo expansion. Now they're not being taken into lymph nodes and they undergo monoclonal expansion and they increase to greater than 5,000. All right, 5,000 cells per ml. So it's not actually a marrow disease because it's chronic. So I'm saying it's mature, and it's not actually a marrow disease. You have peripheral blood disease, and the survival is quite good. It's the 10-year survival, and it is very important that we see CLL along with most of the other diseases like SLL, small lymphocytic leukemia, because of the fact that they are so kind of related. Now CLL, the markers are going to be simple: CD5, all right, and CD23, all right, CD23. But definitely, if we are saying that it's going to be a pre, so or an immature, then we can say CD19, CD20, 21, 22. 17A, 17B, and serum IgM. So if it is one of the immature cells, then it has bad prognosis. Correct. It has bad prognosis. Now, very important to understand is that these CLL kind of causes what does CLL actually cause? CLL causes, it's mostly asymptomatic. It's asymptomatic, just detected by a high lymphocyte count, and then you want to go into its evaluation. So it's very important for a CBC to be read equally well. Then it actually shows a lot of lymphadenopathy, which is kind of painless and asymptomatic. Again, it's going to be warm antibody positive. That's kind of interesting because any autoimmune hemolytic anemia that you want to think of, any splenomegaly you want to think of, but splenomegaly again, it comes as a part of SLL, small lymphocytic leukemia now, and pancytopenia is kind of rare because your bone marrow is kind of perfectly normal. What you're going to see on a peripheral blood smear is that you see a candy blue lymphocytes. You can see lymphocytes. Lymphocytes are usually smaller. You also see smut cells. Smut cells are kind of very important. Fish genetics, when you do fish studies, you see that there's going to be 13q deletion, all right, and there's going to be a lot of mutation of IG, or any IG actually, and trisomy 12 or deletion of 11q or deletion of 17 is kind of bad prognosis. Beta 2 microglobulin is bad prognosis. ZAP 70 is bad prognosis. Now Richter syndrome is basically transformation of a low grade into a high grade beta cell lymphoma or an Hodgkin lymphoma. So usually when a CLL gets transformed into a DLBCL, we need to be kind of worsened. If it kind of switches to SLL, that's fine. But if an SLL goes back to DLBCL, we are into deep trouble. Yes. So CLL becomes more and more clear when we actually go into and study DLBCL or SLL because of the fact that they all come into non-Hodgkin beta lymphoma, and they kind of help us understand it much better. What is important to understand is that the treatment is good now. We've come up with a good regime. The simple regime is going to be FCR. So we do a rituximab, we do a cyclophosphamide, and we do fludarabine. Now rituximab is a CD5, right? So we know that, and cyclophosphamide is alkylating agent, and fludarabine is something that we need to remember. So rituximab is something that is used, all right, and why do you want to treat it? Can you leave it? I mean, it has a good survival rate, right? So unless there is a constitutional B symptoms like fever, lymphadenopathy, and high lymphocytes in the count, very high lymphocytes, and massive lymphadenopathy or marrow failure, if ever it occurs when it's going into aggressive form like a DLBCL or a MBL, monoclonal beta lymphocytosis, right? Whenever that actually goes in, we need to get into treatment, right? And or if it's an autoimmune hemolytic anemia, because it's going to be unresponsive to steroids, we need to get into treatment, right? So that's the reason why we are actually getting into this particular case. Rituximab is important. Rituximab, trastuzumab, these are these important drugs that we have, right? And so they target CD20. Why did I say C5? For some reason I said C5. They actually target CD20. Sometimes I just lose my head when I'm saying stuff. They target CD20, and I think that is it for CLL. I'm just trying to get into why we do definitely use rituximab. What other drugs do we use? I'm thinking of that because in CLL, in CML, we've been using simple drugs like tyrosine kinase inhibitor, imatinib, and dasatinib, and stuff like that. But when it came to ALL, we use drugs like vincristine, doxorubicin, methotrexate, cyclophosphamide. We've been using cyclophosphamide in CLL as well, but yes, in CML we use something which is very different because of the tyrosine kinase part. But in AML we need to also understand that in AML we've been using something like we've been using doxorubicin, daunorubicin, and cytarabine, and then also all transretinoic acid. Also, we need to understand that in multiple myeloma, we've been using something like if I can remember well, in multiple myeloma, we've been using I think again doxorubicin, and we've been also using plasmapheresis and rituximab. Yes, we've been using rituximab. Now we've not been using cyclophosphamide. We've been using cyclophosphamide, sorry, my bad. So in plasma cell multiple myeloma, we've been using lenalidomide and bortezomib and dexamethasone and cyclophosphamide. But what I'm saying